Hello everybody, I'm Anush Yastani. I'm the Director of Research and Education for the Queensland Fertility Group and a Director for Eve Health, and today we're talking about what's new in the management of fibroids. This presentation was originally given to the Fibroid meeting on May 29th, 2007 in Brisbane, Australia. And so the first thing I would have to say here is my declaration of interest. These are my appointments, and you can see the funding that we've received from the following organizations for research and education. So when we're talking about fibroids, we are going to address in this presentation two aspects: firstly, diagnosis, and secondly, the management of fibroids. Fibroids can be classified in a number of ways. The standard classification system divides them into subserosal, intramural, or submucosal fibroids. The FIGO classification, in fact, goes from 0 to, in fact, 8, though we're going to be talking from 0 to 7 over here. And so a subserosal fibroid is when the center of the fibroid is outside of the middle third of the myometrium. A pedunculated subserosal fibroid is a type 7 fibroid. A type 6 is where most of the fibroid, more than 50%, is outside of the myometrium. More than 50% inside of the myometrium is a type 5. An intramural fibroid is when the center is within the middle 1/3 of the uterus, and a type 4 is where it is contained, and a type 3 is where it actually indents the endometrium. As far as concerned, a submucosal fibroid is a fibroid where the center is deeper or more superficial to the central third, and here a type 2 fibroid indents the endometrium, and a type 1, more than 50%, is within the endometrial cavity, and a type 0 is a pedunculated submucosal fibroid. Now, fibroids can in fact be a variety of grades, and we may have a grade 1 through to 5 as the classification system over here. When we're talking about imaging, there are a number of modalities, and we're going to talk briefly about ultrasound, saline infusion, sonography, hysterosalpingography, computerized tomography, and MRI. So 2D ultrasound is the most easily available form of imaging available. It is a defined hypoechoic mass with a sharp, discrete refractory shadows. Cystic anechoic areas of degeneration may be variable, and there's this classical posterior shadowing. It also demonstrates a mass effect. So ultrasound is an excellent way of imaging. However, it is a dynamic investigation, and static images sometimes make it a little bit more difficult to assess exactly the fibroid. Saline infusion sonogram allows a visualization of the endometrial cavity using saline as a negative contrast medium. And here the location of the fibroid may be a little bit more clear, as it is in this situation, where you can see the fibroid over here indenting the cavity a little bit better. It provides additional spatial orientation to just a 2D scan. 3D ultrasound adds a further level of definition in that it allows volume acquisition and also the capacity to report off-site, and allows us to visualize the fibroid in relation to other structures. And so you can see over here that the reconstructed image gives nice spatial localization of the fibroid with 3D acquisition. 4D acquisition simply means that this occurs in real time. A hysterosalpingogram allows visualization of the endometrial cavity, and this is not a great methodology for assessing fibroids, but it does allow you to see exactly where a fibroid is in relation to the endometrial cavity. And again, you can see it sitting over here, indenting the cavity. What it doesn't give is exactly what's happening on the outside and how large this fibroid is. A CT scan gives very limited resolution of pelvic structures, and I'm going to show you two imaging modalities of the same pelvic mass. This is a patient who presented with a pelvic mass, and you can see that in these images where we have a CT and an MRI side by side, it is chalk and cheese. The MRI quite clearly demonstrates the fibroid over here, whereas with the CT scan we have something happening in the pelvis, and it's really quite difficult to differentiate what is what. MRI provides excellent soft tissue characterization, and this is almost an anatomical picture that you can see over here with the uterus, cervix, vagina clearly outlined over here, bony structures at the back, anterior abdominal wall. It is an excellent assessment, and it is easy to localize fibroids in this. In addition to the sagittal view, you also have the capacity to image the fibroid in a number of other ways. So this is it here in the sagittal view. If we have a look at it then in a axial view, and then finally a coronal view of the same fibroid, gives you very clear imaging and localization of a mass. It also allows visualization of coexistent pathology such as a ovarian cyst. It also allows differentiation from other pathology such as an adenomyoma presenting as a fibroid, an important distinction to make when we're operating on fibroids. Talking about management in the second component of this talk. Management of fibroids can be undertaken in a number of modalities. Firstly, you can do nothing, and it's observational management. The malignant potential of fibroids is quite low, and we'll talk about that a little bit more in a moment. Medical management may be with GnRH analogues and selective progesterone receptor modulators. Interventional management includes management such as HIFU or uterine artery embolization, and surgical management, uterine artery ligation, myolysis, myomectomy, and hysterectomy. As we're talking about fertility, our accept statement from 2011 really places uterine artery embolization, high intensity focused ultrasound, radiofrequency thermal ablation, and myolysis really in an experimental category, and therefore we will not be talking about these, nor will we be talking about observational or hysterectomy management in the setting of infertility. So, fibroids, we need to acknowledge that our understanding of how fibroids grow has changed quite significantly. Up until recently, the thought was always that this is a purely estrogen-dependent disorder. However, it is now quite clear that progesterone plays a very significant role both in the facilitation of the estrogen effect, but also in terms of blocking apoptosis. GnRH analogues have been the basis of therapy for a number of years, and we know that these significantly reduce the size of the uterus in less than 18 weeks by 300 mils, in more than 18 weeks by almost a litre in terms of volume. However, it's very important to realize that these will soon return to pre-treatment volume after cessation of the treatment. It is very useful in terms of maintaining hemoglobin in anemic patients, and it may alter the operative approach, that you may go from an abdominal procedure to a vaginal hysterectomy procedure or a laparoscopic approach. There is a reduced intraoperative estimated blood loss, and certainly in terms of laparoscopic or open procedures, there's no significant difference between those based on view. Our accept statement clearly acknowledges the role of GnRH therapy, and we have level 1 evidence that this is appropriate treatment in some women. Hysteroscopically, GnRH therapy has been shown to improve visibility and reduce vascularity and reduces the intraoperative medium absorption. This is the effect of GnRH analogs on a fibroid, and this is a young woman who presented with a large fibroid, as is demonstrated over here, and she was commenced on GnRH therapy, and in fact this large fibroid converted into this small mass after 3 months of treatment. So what was potentially quite a large intervention wound up being a very simple hysteroscopic myomectomy. Selective progesterone receptor modulators such as mifepristone and ulipristal have been available in Australia for some time. Mifepristone unfortunately has a very limited benefit in the use of fibroids, and we will not be addressing. Ulipristal has become available in Australia, and it's a selective progesterone receptor modulator. Here you can see its similarity to native progesterone molecule. It binds to the progesterone receptor with high affinity and has both antagonistic and a partial agonist activity. It binds to the androgen receptor with minimal affinity, as to the estrogen receptor where there is no affinity, the mineralocorticoid no affinity, and it does have some binding to the glucocorticoid, but there are no significant human effects as a result of this. Its actions are leading to amenorrhea and fibroid shrinkage, and it does cause menstrual disturbance. There is some vasomotor changes, and some women complain of breast tenderness, though overall this medication is very well tolerated. Comparing GnRH analogs with selective progesterone receptor modulators, GnRH analogs work on the anterior pituitary and cause pituitary downregulation by causing a hypogonadotrophic hypogonadic state. Selective progesterone receptor modulators also act on the anterior pituitary to inhibit ovulation, however cause normal gonadotrophic normogonadism. Also act directly on the fibroid by inhibition of cell proliferation and promotion of apoptosis, and that's really quite an important effect because it causes long-term effects. On the endometrium, there's inhibition of menstruation, and there's just progesterone receptor modulated associated endometrial changes, or PACE. PACE, or the progesterone receptor modulator associated endometrial changes, occur in about 70% of women at the end of 3 months of treatment. It's a reversible change, and while it may look frightening on first look, it is in fact quite distinct from hyperplasia and has no pre-malignant potential. This is comparing hyperplasia with PACE, and you can see quite significant differences in all of these modalities. And there are a number of changes that occur with this, but the most important thing is that this can be quite clearly differentiated from both hyperplasia and malignancy, and it is self-limiting. So what is the role of ulipristal? Well, 5 milligrams ulipristal daily controls uterine bleeding in more than 90% of women, shorter median time compared to GnRH analogs, and corrects anemia well. It has a more sustained effect in that reduction. It is useful in long-term treatment of fibroids. So looking at repeated courses of ulipristal, you see that repeated courses cause shrinkage of the fibroid, though most of this has been achieved after the third course. There have been a number of pregnancies reported after and during ulipristal use, and these have been summarized in 2014, and these have occurred both assisted and in a spontaneous way. And this is a flow diagram of these, showing that of the 21 patients wishing to fall pregnant, 15 achieved the pregnancy, but only 2 of these were without surgery. And this is one of the patients who achieved a pregnancy without surgery. And you can see here really on the left-hand side a very distorted uterus, and with the management with ulipristal, these shrank quite significantly, and in fact you have a relatively normal looking uterus at the completion of treatment, and this was associated with a spontaneous pregnancy without a myomectomy. The other pregnancies that have occurred have unfortunately occurred with the use of myomectomies, and allowing for the current climate, most of these have occurred through a myomectomy, an open myomectomy. Out of the 18 pregnancies in total, there were 13 live births and 6 of them resulting in miscarriages. Coming on to the surgical options for a myomectomy, this can be performed both in a hysteroscopic modality, open, laparoscopic, and by laparoscopic I also include the robotic modality. Techniques that are available for hysteroscopic myomectomy include a laser ablation, where the laser through contact ablates the fibroid directly. Loop resection is the traditional way of managing fibroids, and we literally just resect one segment of the fibroid at a time, and this is done with a distending medium, and it's usually performed as a day procedure or may also be performed in an outpatient setting. In situ morcellation with a device such as MyoSure allows you to chomp the fibroid literally and dispose of the chips in the same procedure. Excellent modality for removing particularly type 0 and type 1 fibroids. Open myomectomy may be minimally invasive to midline, and in minimally invasive techniques we often use laparoscopically assisted myomectomies. A myoma unsuitable for laparoscopic route is one that's very large, more than 10 centimeters, multiple fibroids, more than 4 centimeters. If there's limited access, for example, the broad ligament, though this is more for the traditional laparoscopic approach rather than for a robotic access, and if there are any contraindications to morcellation. The laparoscopic approach is associated with less severe postoperative pain, a shorter hospital stay, less postoperative pyrexia, and there's no difference in complication rates. There's no significant difference between reproductive outcomes after laparoscopic or abdominal myomectomy, though initial reports had suggested that there may be an increased dehiscence rate. There's no difference in uterine artery ligation in Australia, mainly performed laparoscopically, though it's also been described vaginally and under ultrasound control, and the uterine artery is readily accessible in the ovarian foci, and these can be either permanently or temporarily clipped. So in the laparoscopic approach, there have been case reports of uterine rupture, leiomyomatosis, and disseminated malignancy as far back as 2007. And why does this happen? Well, it's been the way that we've removed fibroids by morcellation. And unfortunately, this technique, while very efficient, is associated with chip formation. And these chips usually have not been a problem. Case, and this is Amy Reed, an awful situation where Amy, who passed away just this week, had a leiomyosarcoma diagnosed as part of her treatment. Now, Amy had been diagnosed with a large fibroid as part of postpartum menorrhagia and was seen by an oncologist, had an MRI, had all of her treatments and her assessments performed, and was then offered a laparoscopic hysterectomy where the uterus was morcellated. Unfortunately, a leiomyosarcoma was diagnosed afterwards. Amy waged a serious campaign, and as a result of this campaign, in fact, the FDA issued a caution about morcellator use and cancer deaths, and very quickly thereafter then came a safety communication in April of 2014 instructing caution with the use of morcellation in fibroids, and in fact J&J then removed the power morcellator as part of this. Now the issue here was not the instrument, the issue here is the morcellation in itself and how the performed. We then very quickly at the Royal Australian New Zealand College of Gynecologists then also provided a statement following this, clarifying that the incidence of leiomyosarcoma is in fact quite low, somewhere between 2 per 10,000 to 3 per 1,000, depending on the study population. And that there are a number of risk factors, including age, postmenopausal status, African American ethnic background, exposure to tamoxifen, history of irradiation, a hereditary leiomyomatosis or renal cell carcinoma, and then also childhood survivors of retinoblastoma. In the clinical assessment, practitioners should be alert to the possibility of malignancy if there is a rapidly expanding mass, abnormal uterine bleeding, ascites, lymphadenopathy, evidence of secondary spread, obviously, and a pap smear should be taken as part of the assessment. Patients should have preoperative imaging by ultrasound, and we fell short of recommending MRI for everyone, as the risk factors for leiomyosarcoma increase at large size, tissue signal heterogeneity, central necrosis, ill-defined margins, ascites, and invasion. Now, some of these, such as large size, tissue signal heterogeneity, and central necrosis, also occur with non-malignant disease. Obviously, invasion and metastases are evidence of malignancy. If we look at the impact of laparoscopic versus abdominal hysterectomy, and abdominal hysterectomy here assumes that no morcellation whatsoever occurs, is we will see that there will be fewer overall deaths if all laparoscopies for fibroids are done laparoscopically. In fact, quite a significant reduction. However, we trade this for more deaths from a leiomyosarcoma. There is a lower transfusion rate with laparoscopic versus open procedures, a lower wound infection rate, lower venous thromboembolism, less incisional herniae, an additional 0.85 QALYs over 5 years. But there are some issues with this modelling, in particular the incidence and the effect of upstaging, and also complication rates in this model are a little bit more optimistic, shall we say, for a laparoscopic approach. So the recommendations for the use of an electromechanical morcellator, and this in Australia now is becoming more and more difficult, really are as follows over here, and really it means appropriate training and credentialing of the use of this instrument and containing any fallout. In fact, the FDA has now approved the morcellator bag to prevent the tissue of spread, and this is the type of device where in fact the fibroid is contained within the bag and morcellation occurs in the bag. Robotic myomectomy has become more popular, and so far the evidence suggests that it's more time consuming, more expensive. There's really no significant difference in any of the surgical parameters, and it can be performed as a single site. However, the incidence of robotic procedures is increasing quite significantly, and I would suggest that some of the studies that we're seeing at the moment really reflect the use of this technology in its infancy, and as surgeons become more proficient with the use of the robot and apply it more, that we will see its place established. So what should you do with your patient with fertility problems and fibroids? Well, the diagnosis is made on ultrasound, and ultrasound is now part of the initial assessment of all patients with infertility. Management should occur if they're symptomatic, particularly if it's submucosal, if they're intramural, if there are multiple failed cycles, and this is in line with our accept statement. Clinical risk assessment should occur, including a pap smear, a PIPEL, an MRI, or a hysteroscopy where needed. If it's a type 0 fibroid, then hysteroscopic myomectomy is probably the most appropriate management, and we would normally remove the specimen at the time of the procedure. For a type 1 to 2 fibroid, a hysteroscopic myomectomy may be performed. If it's large, this may occur in a two-step procedure, or you may consider the use of a medication such as a GnRH analog or ulipristal to shrink this fibroid down prior to surgery. Type 3 to 5 really means a laparoscopic or open myomectomy, which may or may not be combined with a GnRH analog or ulipristal, depending on the size of the fibroid and the clinical circumstance. I would like to acknowledge my colleagues at Eve Health and at QFG, my colleagues at Ages and Ranscog, and in particular also Sogiscan for providing all of this material.